Hello, I'm Dr. Nadege Gunn, community hepatologist in Waco, Texas, and it is my distinct pleasure to be a part of the Chronic Liver Disease Foundation Liver Connect 2024, and also to have the honor to interview Doc on the Street, Dr. Sujit Janardhan, who is the medical director of liver transplant at Rush and also the weight intervention and liver disease clinical program director. So Dr. Janardhan, welcome. How are you today?
Doing great. It's a great meeting.
Great. I think so too. This is one of my favorite meetings by far.
Yeah, it's the first time I've had the pleasure of attending this meeting, but everyone's told me such wonderful things about it, and it turns out to be very true.
Let me tell you this. We both just experienced the most amazing MASH forum, from diet and exercise, new clinical trials on the horizon, new treatments. I want to know from you, how did you take that all in, and what is it going to do to change your practice?
I think the thing that was so exciting about that forum was it wasn't just talking about data. It was really looking into the future and thinking about how, now that new therapies are available, how are we going to utilize this? How are we going to incorporate lifestyle management? How are we going to risk stratify patients? And there've always been abstract ideas in the past, but now we have a new therapy to incorporate along with lifestyle management that we have to think future. And I think it's just really exciting. And so the way that I absorbed most of it was really thinking about patient identification
Right.
and then comprehensive care plans. So the talks on biomarkers were really spectacular, and the imperfection
Right.
of these biomarkers, and it got myself and the person who was sitting next to me, my boss, talking a little bit about, well, maybe these biomarkers are meant to look for liver fibrosis.
Mhm.
But maybe that's not the marker we should be looking for. If they're imperfect at predicting liver fibrosis, maybe we should be thinking about which biomarker is best at predicting outcomes, like the development
Absolutely.
of cirrhosis or decompensation, which it's a difficult thing to do
Right.
with a single biomarker. But maybe that's the ideas of incorporating concepts of systemic inflammation and how do we
Absolutely.
do those things. And then thinking about treatment, I was so excited to see a dietitian
Mhm.
has a true understanding of obesity medicine. Obviously, as the program director of our obesity program that we have embedded in our liver clinic,
Mhm.
I feel very passionately about the fact that hepatologists should be doing obesity management
Right.
and lifestyle management. Um, a lot of people feel like it's an exercise in futility, and I think that we've proven that to be not the
Not
case.
true. Right.
When we have the adequate training to do obesity medicine and we have the adequate resources,
Absolutely.
both of which are difficult to achieve on the average hepatologist day.
Let me ask you, if you don't mind. I think the biggest issue, or not even issue, but the question that many people want answered is, how are you going to use newly approved treatments in your practice on the continuum of clinical trials that are actively available? How are you going to decipher what to do in your particular patient population?
I think it's a great question, and I just love the way that the past year has folded out, right? So we had a medication, obeticholic acid, that was denied approval, or
Right.
denied early approval, um, due in part to metabolic dysfunction, or like metabolic dysfunction that it was associated with dysglycemia. And then we had a name change that said, let's not call this non-alcoholic fatty liver
Hmm.
disease. Let's call this metabolic dysfunction. Let's put this disease in the space of the metabolic syndrome. Um, and then recently there was an NHANES study that showed that there's different metabolic profiles of different patients with NASH. Oh,
Hmm.
sorry, with MASH. Um, and
Still got to exercise
it's
that.
still, yeah, it's
Yeah.
still difficult to get, but that some patients might have a profile that are male, more dyslipidemia, more chronic kidney
Right.
disease, and then other patients, female, obesity, diabetes. And so I think understanding the metabolic profile of the patient with MASH
Hmm.
might help us inform how exactly we want to incorporate those treatments. Obviously, it's not part of the label, but we know that there's lipid lowering effects
Hmm.
of Resdifra.
Yes.
And so especially people that have those issues that
Hmm.
it's a lipid driven MASLD or MASH,
Hmm.
those are the people. But as of right now, there's no reason, even if a person is diabetes featured in terms of the pathogenesis of their metabolic syndrome and MASH, there's no reason why we wouldn't want to initiate therapy with Rezdiffra
Right.
into that practice, because there was, as we discussed during this session, people that were diabetic on GLP-1 therapy still gained benefit when
Right.
Rezdiffra was added.
And I appreciate what you're saying, because you're saying, if I'm understanding correctly, that we have to tailor the approach to the patient that's sitting in front of us.
Without a doubt, I think that to just say, okay, well, this person has obesity and diabetes, we are going to just treat them with Rezdiffra, but not optimize their diabetes and obesity management would be a mistake.
Absolutely.
And especially when we see the cardiovascular benefits now of GLP-1s and early semaglutide in particular.
Yes.
And so I think that the drug therapy should be incorporated really regardless,
Right.
for the patients that are moderate to advanced fibrosis. But it has to be part and parcel of a comprehensive program that's lifestyle oriented as well.
So, because we have your expertise and you lead a weight intervention program at your center, can you speak to us a little bit about that and how you incorporate a multidisciplinary approach, how you work with your endocrinologists and other specialists in the comprehensive management of these patients? We would be remiss if we didn't ask you that
Yeah,
question.
Dr. Gunn, I've been waiting for you to ask me that question this entire time. I'm very excited about it. So as a hepatologist in 2018, my boss suggested, hey, you want to go check out this Obesity Medicine Association course? And it was just really everything that I've always wanted to know. I'd been doing lifestyle management as a treater of MASLD for quite some time, but it was really understanding the physiology and understanding the science behind obesity and weight loss that was really a game changer. And several of my APPs came with me to this course, and they were also equally excited. So from that point, we said, okay, let's create an organized program that helps us affect weight loss, and let's make it multidisciplinary. Let's make sure that we're addressing all components that are relevant to weight loss, whether it's exercise, psychology, motivational interviewing, obviously diet and nutrition, medications. And so that allowed us to really provide, from an obesity standpoint, a comprehensive care plan. Now, over time, I realized that as a hepatologist, I don't have time to see patients quite as frequently as I would need to do effective weight loss management. And that's where my APPs came in. They had the ability to see patients monthly. It's actually recommended patients can be seen every 2 weeks, but even my APPs don't have time for that. But it allowed us to, in a busy hepatology practice with busy hepatologists that are dealing with patients that are transplant patients and advanced cirrhosis and decompensated, that those patients needs the hepatologist's attention. And the patient that has F2 fibrosis also needs weight management, and it needs to be, in my opinion, it needs to be weight management by a hepatologist. And our APPs are able to do weight management while also understanding the complexities that might be related to the liver disease. Because when we push weight management off towards a primary care setting, some things get taken away that might not be appropriate. For example, when a patient has advanced fibrosis, maybe they say, oh, that person has liver disease and you should stop their metformin, when we know that maybe metformin might improve their risk of HCC, or stopping their statin, which of course we know is not the best idea in our MASLD patients. And then understanding when patients have early cirrhosis, what are the dangers of weight loss? What are the dangers of, because we know that weight loss induces muscle mass loss. So how do we induce weight loss without causing muscle mass loss? So all these little nuances that are important from a liver standpoint. So that's from a functional standpoint, by incorporating our APPs and making a comprehensive program, it allowed us to do this while still maintaining our hepatology practice. But from a multidisciplinary standpoint, I'm glad you asked about that as well. We've collaborated with actually 60 other providers at Rush and developed a comprehensive metabolic health consortium. So this includes representatives from nephrology for chronic kidney disease, sleep medicine for sleep apnea, psychology for things like eating disorders and trauma that drives metabolic syndrome, obviously cardiology, endocrinology, OBGYN for PCOS. And we've developed a care pathway that allows patients to come actually through preventative medicine, which we thought was a perfect home for this, and get screening tools for all of these 13 different subspecialties,
Mhm.
and determine, and these are screening tools that were given to us by the
Right,
subspecialties. So we were talking in this session about when do we need to send it to a
right.
cardiologist? And this is the cardiologist telling me, hey, these are the patients that I need to see. This is the
Mhm.
nephrologist telling me that. And so these comprehensive screening care pathways allow patients to come in and then get referrals to the appropriate departments.
That they need, right?
And what that allows them, obviously, is that they then end up with a comprehensive metabolic care pathway. So that's how we've incorporated not just weight management,
Mhm.
but comprehensive metabolic care into our practice.
That's very interesting. I think a model that may need to be replicated at across other types of programs, whether you're in an academic or rural practice like I practice in.
Right.
And I really thank you for that information, and your experience is really well received. With that, I'd like to thank you for being here, and wish you well for the rest of the conference, because there's a lot to learn here and such a great platform to network.
It's really a great conference, and thank you so much for taking the time to talk with me.